Hello, everyone. Thank you for joining us today for our first webinar, this is our third webinar now in the peer-to-peer series this fall, brought to you by the National Collaborating Center for Methods and Tools. My name is Claire Howarth, and I am a research coordinator at the National Collaborating Center for Methods and Tools, and I will be moderating the webinar today. So just a few housekeeping items to start, and then we'll get into our presentations. So please use the chat box to send your questions, and make sure to send your questions to all participants and not just privately to the host. There will be several question and answer opportunities throughout the webinar today, so please send your questions in the chat box at any point during the presentations, and we'll make sure to answer them during those question and answer periods. Now, if you can't see the chat box, you can hover over the slides or really anywhere in the WebEx platform should work, and you'll see a little blue speech bubble appear at the bottom of your screen. So if you click on that, the chat box will open for you. We also recommend that you use a wired internet connection today, and if you do encounter any technical issues, the phone number for the WebEx 24/7 helpline is on this slide. Also under panelists, you will see Kate Turner. She is helping to support the webinar today. So if you have any technical issues, please feel free to send her a message. The slides from today's webinar will be available online in both English and French approximately 2 weeks following the webinar, and a recording of today's webinar in English only will be posted online as well. There is a link on the slide, and there should also be a link in the chat box about where you will be able to access the slides and the recordings. And we will also be posting links through our social media accounts, which are Twitter, LinkedIn, and Facebook. So we are just going to start today with a quick poll question to get a sense of how many people are joining us today. So how many people are watching today's session with you? Either just me, 1 to 3 people, 4 to 5, 6 to 10, or more than 10. So I'll just give you a few seconds there to fill in your answer. Okay, great. Thank you for everybody who has answered. So just once again, I'd like to welcome you to our peer-to-peer webinar series. This webinar series is designed to share success stories of evidence used or building capacity for evidence in public health practice in the real world. And our hope is that this will help demonstrate that evidence-informed decision-making, or EIDM, is achievable for anyone working in public health. Just a quick little introduction into the National Collaborating Center for Methods and Tools and the National Collaborating Centers as a whole. So the NCCMT is one of 6 national collaborating centers across Canada, and together with the 6 national collaborating centers, we are the National Collaborating Centers for Public Health. Each center focuses on a different public health priority topic area. The NCCMT is located in Hamilton, Ontario, and our mission is to enhance public health practice and policy in Canada by providing leadership and expertise in evidence-informed decision-making to Canadian public health organizations. So this slide just shows some of our resources that we have available online. So these are all available through our website. So we have the Registry of Methods and Tools, which is a collection of over 270 methods and tools for knowledge translation in public health. We also have online learning opportunities, including our 13 online learning modules, and those are all free for access as well. We also offer workshops. We have Public Health Plus, which is a repository of high-quality pre-appraised studies and reviews relevant to public health. We also have several video series that are available on our website, including our popular Understanding Research Evidence series, which goes through important concepts for evidence-informed decision-making and really quick and easy to understand videos. We also do outreach and have networking opportunities. So you may see us at a conference, and if you do, please come over and say hi to us. So today's webinar will feature stories from the second issue of the Evidence-Informed Decision-Making Casebook, which launched at the beginning of October. The link to the casebook is on the slide, and it will also be in the chat box. And if you haven't looked through it, I really highly encourage you to look through it and read the author's stories. So our presentation today comes from Lori Greco and Dr. Megan Ward from the region of Peel Public Health. And I will pass it over to them to begin.
Thank you very much, Claire. Can you hear me okay?
Yes, I can hear you perfectly.
Great. Thank you. Well, it's our pleasure to present today to tell you the story about the Knowledge Broker training at Peel Public Health. I am Lori Greco, and I was until recently, when I retired, the Central KB at Peel Health. I was in the role since 2014, and I've been at Peel Health just over 10 years. And I'm co-presenting today with Dr. Megan Ward, who's the Associate Medical Officer of Health and who's responsible for the evidence-informed decision-making strategic priority here. And Dr. Ward has been at Peel Health since 2005. So we'd like to thank the National Collaborating Center for the Evidence-Informed Decision-Making Casebook and for the opportunity to present today. And Claire, how do I advance the slides?
So if you can see thumbnails, you can just click on the next thumbnail, or if you hover over the slides again, you should be able to see a little bar to the left-hand side of your screen that has up and down arrows.
Okay, thank you. So the outline of our presentation today, in order to tell you about our journey to using evidence and about the KB training, we'll take you through some background and rationale, the objective of the KB training, some information about the initiative itself and its implementation, how we evaluated the training and the results, and about our lessons learned. Evidence-informed decision-making is one component of a 10-year strategic priority at Peel known as end-to-end public health practice. EIDM involves the application of research to practice by conducting research reviews using robust methods for finding, appraising, and synthesizing evidence. What you see on the slide is our end-to-end public health practice model, which shows there are many different processes which support public health practices. And research reviews could be conducted to support several of these overarching processes, such as how we go about defining a problem, developing program options, or deciding on interventions. It's important to note that when we began 10 years ago, there were actually almost no knowledge brokers around in the community, and now there are knowledge brokers available. There are many more with the skill set and with experience who can actually be hired and then learn specific organizational processes. But when we began, we knew we had to train in-house because there weren't people around for us to recruit. Over the past 10 years at Peel Public Health, capacity building for evidence-informed decision-making has included, in the very early days, an executive training program project in 2009 to develop the processes and tools for conducting research reviews. We participated in a knowledge broker case study in partnership with Dr. Maureen Dobbins from McMaster University from 2009 to 2011 to determine the effect of the KB role in the organization.
Specific training included over 130 managers over the 10 years and analysts who attended the McMaster University week-long EIDM course. We conducted 2 waves of knowledge broker training between 2014 and 2018, plus tailored training for conducting research reviews for managers, supervisors, and analysts. We implemented 1 central and 6 topic-specific monthly critical appraisal clubs. The organization created a senior KB position in 2014, and we've completed over 85 mentored research reviews to date. So the objective of the KB training was to have more knowledge brokers throughout the organization to support the use of research in program and policy decisions. And in order to have sufficient capacity to really embed EIDM, we felt we needed at least 1 knowledge broker in each of the 5 divisions. And that includes chronic disease and injury prevention, communicable disease, family health, health protection, and the Office of the Medical Officer of Health. So the pictures on this slide are pictures of the graduation on the left, graduation day for wave 1 of the training, and on the right, graduation day for wave 2 of the training. So the training was conducted, there were 2 waves of training conducted over 4 years. The first wave was from 2014 to 2016, and the second wave was from 2017 to 2018. And we're going to give you lots of information about the content of the training, its implementation, and evaluation results. But it's important for us to say that we learned, as Megan likes to say, we rolled up our sleeves and figured it out as we went. The training evolved very organically over time, and we learned a lot in wave 1 that we applied in wave 2. So in general, to set up for the training, the analysts were identified in each of the divisions by their directors, and they were identified based on their ability, their experience with conducting research reviews, their specific role in the division, and their career timing. All the candidates had to have conducted several research reviews so that they were fully competent in the process before the training began. And the training content was based on an in-house literature review that we conducted to identify knowledge broker skills and activities. And on this slide, you'll see the titles of 2 of the key papers that were used in the literature review and that informed the content and implementation of the training. So what exactly did we focus on in the training? Based on the research literature that was describing and evaluating knowledge brokering, the training content focused on mentoring teams conducting research reviews. This involved providing guidance and significant technical support to teams to help them define a question and then search for, retrieve, and quality assess research, to interpret results and synthesize research evidence for their program decisions. It focused on facilitation, so facilitating dialogue, collaboration, and relationship building in order to build capacity to find and use research in program decisions. And an example of this would be leading critical appraisal clubs. We focused significantly on communication. The trainees engaged with all staff. They developed knowledge products and supported knowledge sharing among clients. It involved adapting style and content of both verbal and written communication for senior decision makers, analysts, as well as frontline staff. It involved synthesizing and summarizing research in a variety of formats, including the full reports and one-page knowledge translation summaries. We focused on networking. We wanted the knowledge brokers to become a known resource for EIDM within their division and across the department. And they participated and continue to participate in knowledge brokering community of practice to support ongoing learning and collaboration among the KBs. So how did we work with these analysts to build their skills? The implementation of the training program evolved, the structure and methods of the training, as I've said, evolved over the 2 waves of training. And for Wave 2, they were informed by the evaluation of Wave 1. The methods of the training were developed based on adult learning principles, which included goal setting, self-direction in the form of an individualized learning contract. We focused on their current skill and experience, and we used real-world work for assignments, and then there was lots and lots of collaboration. In Wave 1, 7 analysts started the training, and Wave 2 included 5 analysts. All of the divisions in the department were represented in each of the trainings. Each of the analysts devoted 1.5 days per week to the training, and as I've said, the training took place over 2 years. The first wave was 22 months in length, and the second wave was 15 months in length. Specifically, the learning methods included a combination of meetings where we discussed challenges, we set goals. It involved practice and co-mentoring with the senior KB. All training, observations, practice, assignments, and research reviews were based on real-world work and practice decisions that were happening in the organization at the time. So the practice and co-mentoring research reviews were not based on hypothetical practice examples. And although 1.5 days per week were set aside for the training, the actual work was contributing to programming of the department. And in this way, the methods meant that the training was much more like an apprenticeship rather than strictly classroom teaching. So the specific strategies included reading assigned literature on knowledge brokering, completing a knowledge brokering self-assessment based on a framework of KB skills and attributes from the literature, and then this led to developing an individualized learning contract that detailed objectives, learning strategies, and timelines. The trainees completed tailored projects that were related to knowledge brokering, for example, teaching statistical concepts. They observed the central KB facilitating various steps in the EIDM process, for example, conducting critical appraisal meetings and mentoring analyst manager teams through research reviews. Then they practiced as above, followed by one-on-one feedback sessions with the KB where we discussed challenges and next steps. They co-mentored all the research review processes along with the KB. They attended regular group meetings with the AMOH, the KB, and other trainees. And they participated in ongoing evaluation of their progress against learning objectives with the training leaders and with their managers. So evaluation took place midway and at the end of the training for each of the cohorts. Evaluation of each wave of training consisted of document review, interviews with the KB trainees to assess change in knowledge, skill, and experience, interviews with their managers to assess change in skill as well as in practice, and reflection by the AMOH and the senior KB to assess organizational impact and training methods.
So then, what were the results of this training? Well, our evaluations found that intensive one-on-one mentoring of the knowledge broker trainees facilitated their learning and their skill development. We noted that, as did their managers, noted that the trainees developed leadership, networking, facilitation, and research review skills. The training team, which combined the skills of a very experienced knowledge broker, namely Lori, with the practice knowledge of a senior leader, who was me, as the Associate Medical Officer of Health, was important for the success of the program. The evaluation also demonstrated that this kind of training takes time. So it was approximately 3 weeks of time per week for me as the AMOH, 14 hours a week for Lori as our central knowledge broker, and 1.5 days per week for the trainees. For me, the time investment included a mix of planning and developing the training with the knowledge broker, Lori, regular training meetings with all of our KB trainees, the evaluations that we were doing, but also very specifically work on these departmental projects that we were using to mentor our trainees. Because trainees work with supervisors and analysts undertaking research reviews, we learned that they had to adjust to the real-world schedules of those folks. And the managers of these trainees needed to commit to the training and then adjust their other workflow as needed. And although these managers were not directly involved in the delivery of the training for the KB trainees, they did meet with them regularly to evaluate their progress. We learned that the learning strategies that include, setting a goal, being observed, practicing, and getting very specific feedback on that goal was the most effective. And then in terms of the lessons that we learned over these 2 waves, one of the most important is the ongoing support from the entire leadership team of the health department ensured that we had the organizational commitment for our trainees over the length of their training. Really, you have to commit sufficient resources and time in order to be successful at the organizational level. We always told our trainees that we really wanted to focus on the needs of their clients. In this case, the team that would be conducting a research review, and that they would start with where their client was and do what it took to help that pair be successful in the research review. We found, or we learned, that developing a critical mass of skilled knowledge brokers actually increases capacity to use research, and it does lead to culture change more broadly in the organization. We estimated, and would say this is true, that the minimum critical mass for our organization of 700 staff, we think, is one centralized knowledge broker plus at least one knowledge broker for each division. So, in other words, about one knowledge broker for each 150 staff. We also learned that training knowledge brokers does result in high-quality, robust research reviews that are actually used to influence practice decisions. The managers feel more confident in decisions when there are high-quality reviews behind them. So let me give you a couple of examples. A recent one in family health was a review that's been done on how to engage high-risk families who are in home visiting programs. In chronic disease division, there's been a recent one on the determinants of mental health in school-aged children and youth. For the Office of the Medical Officer of Health, we've just finished one on identifying and developing employees for leadership roles. In communicable disease, we've done a recent one on effective brief intervention counseling for preventing sexually transmitted infections. And for Health Protection Division, we've done one recently on effective interventions to promote food safety in the home. And all of these reviews, in fact, all of the reviews we've done are available on our website. So we're going to wrap up there. And, just one more thing. We also found that by carefully evaluating the first round of training, we were able to improve the content and delivery of the training for the second wave and actually shorten it by several months. And by developing advanced skill to use research, we found across the whole organization that this does improve critical thinking skills. And for our KBs in particular, it positions them for future leadership roles. And I think if you take this on in your own organization, you should expect some movement within these roles. For example, they might get into a management position eventually. And this results in an ongoing need to either recruit more skilled knowledge brokers from outside the organization or to provide subsequent training waves. So let's finish it there. Our current central knowledge broker is Jackie Morrison, and you can see her contact information on the slide there. And she would be pleased to speak with any of you if your organization is interested in the knowledge broker role.
Great. Thank you so much for that very informative and interesting presentation. So we have a few minutes now for some question and answer. So if you have any questions, please feel free to send them in the chat box to all participants. And we do have a few that have come in. So from Teresa Norton, we had a question about what is PEEL. And I see that our support staff, Kate, has answered it, but I wondered if you would be able to expand a little bit about what is PEEL region.
Sure, it's Megan. So PEEL region is a region in Ontario of 1.4 million people. The local health department serves that population, and the Board of Health for the local health department is the regional council. So the health department is 700 or so staff delivering public health programs to the people of that region. And there are three main cities in the region: Mississauga, Brampton, and Caledon.
Perfect, thank you. So another question from Teresa Norton. Did the participants have other job responsibilities at the same time as the training and mentorship?
Thanks for that question. Yes, they did. The trainees devoted 1.5 days a week to the training over the length of the training. They did have other job responsibilities that they were responsible for maintaining throughout that period. And as we've said, as much as we could, we focused on work that they were actually doing in their divisions to practice the skills of knowledge brokering.
Great. So another question here from Teresa Norton is, has there been a journal article published since the 2015 Born Bomb article?
Casebook, right?
In terms of published literature, I can't answer that off the top of my head. I think the Born Bomb article may be the most recent published, and then our article is published in the EIDM casebook. So that would be, I think, maybe the most recent experience of training knowledge brokers that's documented.
Thanks. And we have one more question from Rebecca Haber. She asks, is there a definition that your organization uses for a knowledge broker?
I don't know that we have a formal definition, but for us at Peel Health, the knowledge broker is a resource to the teams and to the division and to the department. And they're a resource that is highly skilled and trained and able to find research evidence that's relevant to a particular practice question, determine the quality of that evidence and the confidence that you can have in the results of that evidence, and then coach and mentor teams to understand that evidence and synthesize it along with other research and other information in order to inform a decision. So the knowledge broker is really a mentor and a facilitator to implement or realize evidence-informed decision-making in the department.
Great, thank you. So I just have a question too. So one thing that I know I've heard quite a bit about Peel is the top-down approach that has been in place for this work, and how there's a lot of buy-in for evidence-informed decision-making. I was just wondering if you could expand on that, and if there's any key items that helped facilitate that success with having that buy-in and that top-down approach.
Well, I'll make a comment, and then I'm sure Dr. Ward would like to jump in as well. From my perspective, the buy-in or the leadership that was behind this whole strategic direction and the implementation and really the embedding of evidence-informed decision-making in the organization really came from the leadership. It came from our medical officer of health at the time, who was Dr. David Mowat, and from Dr. Megan Ward, who is, as we've said, the AMOH, and who was responsible for the strategic direction. And it was a 10-year journey, and I think it is important to note that the senior leadership in the organization supported this work and saw the value in it and supported it for 10 years. And there was significant resources invested, and I think it really speaks to their commitment to evidence-informed decision-making that this strategy was continually supported for 10 years.
Yeah, and it's Megan, I guess I would add to that in organizations, it's always about choices and how you're going to use your resources in order to really improve the health of the population that you're serving. Because we were really underfunded at the beginning, we wanted robust ways to make choices about practice, and we thought the application of research to decisions would be helpful to make those kinds of choices, and I think that's proven to be true for us. But you know, you can't use research well unless you have people who are pretty skilled in understanding it. And so the knowledge broker, initially our centralized knowledge broker, and then this very skilled cadre of people we have now, has really helped us with the robustness of that method. And that actually helps us make choices among all the different kinds of programming decisions that we have. When the senior leadership sees that as valuable, that robust thinking, then the people who are actually engaged in the work have lots of support behind them. And it's helpful to them. And it also means that across all the divisions in the department, they know that they can take the time to do the review and to take decisions in this way. So it just gives people an extra foundation to stand on and confidence when their leaders are right behind them in the work.
That is wonderful. Thank you. So I just see we have one more question from Kirsten Sears, and she asks, can you speak to how EIDM fits into Peel's process for program planning?
Sure. It's it's Megan. We anticipate that you might like to go to the research in a lot of different steps of the program planning process. So say you're right at the beginning and you're even trying to think about how to think about the problem, say mental health promotion for school-age kids. Well, that's a nice, complex, meaty area of public health practice. And so you might want to go to the literature in that case and find a conceptual framework that would help you with that. But then say you find some things there that you want to know if there's any evidence at all behind a particular kind of intervention for mental health promotion in school-age kids. Well, you might again want to go to the literature and see what it says about effectiveness of interventions. And of course, it will never be the case that the research tells the story for you, because there's so many other there's so many other important determinants of what you choose to do. I mean, there's funding that comes into it. There's the knowledge of your own staff on the ground in the context. There's sort of political and community preferences, what's acceptable in your community, and so on. So there's, other things from data about how big the problem is in your community. So it's just one part of it, but we recognize that the literature actually does offer us things all along the way that helps us to choose more wisely about how we're going to use our resources in the hope of having some impact.
Great. So I think we have just a few minutes for one more question. So from Wahib, we have how much statistics or statistical packages are needed for this work?
Statistical packages? Do you mean like software?
That's how I understand it. Yes, software.
Okay, I'm going to jump in just to start while Laurie mulls that over. But the main thing that we had to add in was a library service, which is not a statistical package at all. But honestly, you cannot get research if you don't have access to it. And we didn't have a connection with the university or anything, so we actually joined a library consortium to get us access. In terms of the analysis of the research and the statistics within the research, we did that with training. So it was actually teaching people enough about research design and about biostatistics in order for them to understand what was in the paper and whether or not it was valid and reliable. So Laurie, over to you on that.
Yeah, I'll just add to that very briefly that we don't use statistical packages here to synthesize or analyze the research. We search for, hopefully, all quality appraised, but synthesized research. So we always start looking for systematic reviews that have already found the available research on a particular topic and hopefully quality appraised it and synthesized it for us. In the case where there is no synthesized research, we do look for more recent single published articles, and we do our best to pull that all together to understand the bottom line on a body of research. Does that answer the question?
Yes, looks like it does.
Thank you.
So I do see we have another question, but I'm going to hold on to it for our second question and answer period, if that's okay. That will take place after the next presentation, just in the interest of time here. So our next presentation comes to us from Farah Bandali and Maureen Devlin at Alberta Health Services. And so I would like to welcome them today for their presentation, and I'll pass it over to them.
Hi. Good afternoon, everyone. Sarah and I are very pleased to present to you today on the Well Child Clinic standardization work that has been happening in Alberta Health Services. But first, we'll just introduce ourselves quickly so you know who we are. I am the Director of Healthy Children and Families, which is within Population, Public, and Indigenous Health in Alberta Health Services. And I've been working in healthcare in Alberta for the last 32 years, ranging from neonatal intensive care units to labor and delivery, to public health nursing, and now in the last 6 years, I've been involved in population health. In Healthy Children and Families, we utilize a population health approach, and we focus on families from preconception up to 18 years of age. We have 5 teams: the reproductive health team, the early childhood team, school health and wellness promotion team, Healthy Parents, Healthy Children team, and a knowledge translation and evaluation team. And Farah is the manager of the early childhood team, and I will let Farah introduce herself.
Hi, good afternoon, everyone. So as I sit with Maureen in the Healthy Children and Families team, and I've been with Alberta Health Services for about 15 years and have led local and provincial initiatives in the area of population and public health, ranging from childhood obesity prevention, school nutrition, public health nutrition, community development, public participation, and more recently in the areas of early child development priorities, such as breastfeeding strategy for Alberta, postpartum depression policy, as well as safe infant sleep and this Well Child Clinic standardization work. So I'm really delighted to have the opportunity to tell you a bit about the standardization work today.
All right, thank you, Farah. So we'll get right into our presentation today, which is titled Making Evidence-Informed Decisions about the Alberta Public Health Well Child Clinic Visits, the Art and the Science, which it truly was. And before we get right into it, I just want to make a few acknowledgements. So in addition to Farah and I, there were many other individuals involved in this work, and I would like to acknowledge Dr. Dolly Bondarian-Zadai, Dr. Cindy Johnston, Sandra Herbison, Scarlett Ngoko, Germaline Valarosa, Dr. Gloria Keys, and our Alberta Health Services Well Child Clinic Standardization Working Group, which included Public Health Zone representatives, researchers, and our Provincial Communicable Disease Control Department. As well, there were many other content experts from across Alberta who were involved in relation to the specific activities and evidence-informed interventions within the Well Child Clinic context. So today what we'll do is we'll be covering the Well Child Clinic standardization process, which out of necessity turned out to be quite a novel approach. We will present the resulting recommended routine and non-routine activities that are standardized for Well Child Clinic services in Alberta Health Services. We will also briefly touch on the implementation that is currently underway and the planned evaluation once we've implemented it fully. So why did we do this? Well, in Alberta, the Well Child Clinics are staffed by public health nurses, and they deliver public health services under the authority of the medical officers of health within Alberta Health Services. So this includes publicly funded immunizations, health assessments, promotion and education activities, which would include things such as growth measurement, injury prevention messaging, postpartum depression screening, as well as opportunities for parents to ask questions, and then for public health nurses to provide any necessary referrals. For example, if a mother is having breastfeeding issues where she needs lactation consultant support, then a referral can be made to a lactation consultant or potentially to a food bank or to a parent-teen class, whatever the family needs. These Well Child Clinic visits occur at 2, 4, 6, 12, and 18 months, as well as 4 years. So if you look at Alberta then, using 2015 stats, we had roughly 56,400 babies born. And if we use the birth rates then from the previous 4 years, that equates to about 282,000 Well Child Clinic visits in 1 year. So that's in 2015, and we know that since then our birth rate continues to increase in Alberta. So you see we have a lot of opportunity in these Well Child Clinic visits to impact early childhood growth and development, health and safety, and family adjustment. So public health nurses are really key primary care providers for these families. The standardization of the non-immunization activities in the Well Child Clinic is really responsive to things such as the growing birth cohort that I just mentioned, the expanded immunization schedule, and the reality of shifting and complex demographics, such as increased rates of poverty, increased immigrant populations where you're required to have a translator in the Well Child Clinic. And so all these things have been contributing to time pressures in the Well Child Clinic visits with no additional resources for public health. So what are the benefits of standardization? Standardization of the non-immunization activities in the Well Child Clinic endeavors to promote consistent and best practices in public health nursing across Alberta. It will ensure that families receive consistent information and guidance on health and parenting issues. It will support public health nurses in making the best use of their limited time and will align their work with parent and child priorities, using the best available evidence while preserving their use of clinical nursing judgment. It acknowledges, strengthens, and protects the public health nurses' key roles in Well Child Clinic beyond immunization. And lastly, but most importantly, it will facilitate consistent data collection for monitoring and surveillance, which will contribute to the ability to measure health outcomes. And this is something that has not been done yet in regards to Well Child Clinic and Alberta Health Services, and this is something that's really important to all of us. Now we'll get into the project. So the main objective of this work was to examine and decide on the routine and non-routine non-immunization public health Well Child Clinic activities to be implemented across the province. So this is just a slide that illustrates the journey leading towards the recommendations that were approved for standardization. And it just gives you just a nice, succinct outline of the work that we did. I'll cover the first two steps, and then Farah will take you through the last three steps. We do want to stress that collaboration and consensus were key principles with this work, and this was a very iterative process throughout the entire project. So the first step was establishing a governance structure. So Alberta Health Services, as you may or may not know, is a very large organization. We have 5 zones, and those zones are North, Edmonton, Central, Calgary, and South zones. And the zones are the operational arms within AHS, whereas us in Healthy Children and Families, we are part of the Provincial Population, Public, and Indigenous Health Team, which I will just refer on to now as PPIH. And some of the divisions within PPIH do have operations. However, in Healthy Children and Families, we are really just focused on primary prevention with a little bit of secondary prevention. So it really is public health in the zones who are responsible for Well Child Clinics. And so they were the main drivers for this work. And of course, they needed to be key stakeholders as well in this provincial standardization process. It was imperative then that both the PPIH and the public health zone leaders were involved in our governance structure. Unfortunately, within AHS, we already had an existing committee with all these leaders who were representatives on this committee. So all the public health executive directors and MOHs and all the PPIH executive directors and MOHs, including the Senior Medical Officer of Health, were all representatives on this committee. And they were all in agreement that this work needed to happen. So this was the committee that we were accountable to and reported to on the project regularly, as well as we incorporated their feedback throughout the process. We also needed a provincial working group that included a mix of zone public health educators, managers, and directors. We had provincial maternal child health researchers, and we had our own health promotion team within Healthy Children and Families that included staff and managers from our early childhood team and our knowledge translation team, including myself and our knowledge translation evaluation team. Then we had ad hoc consultations that occurred throughout this process as well when needed, such as with content experts like nutrition services, oral health, the Head Shape Clinic, tobacco reduction. We also had consultation with other key groups like the zone public health directors, specifically when we had operational concerns that we wanted to discuss with them around feasibility or other issues. We also had committees and key stakeholders that we consulted with and who were responsible for our electronic charting system, which is called Meditech. So this was to make sure that we aligned our data elements for evaluation and ongoing surveillance of the Well Child Clinic activities. So once all that was set up, we also worked on our guiding principles. And these guiding principles were considered throughout all the phases of this work. They were identified at the start of the project to really guide the work and the decisions. And they were chosen based on the context of Well Child Clinic with the following rationale, which is probably fairly obvious to most of you. So health equity is absolutely a guiding principle we wanted to include so that we can ensure that the Well Child Clinic standardization work considers and addresses the provision of support as needed to provide optimum care to all those who come to the clinic. Patient family-centered care was our second guiding principle, and this is foundational in public health Well Child clinics as well as across all of Alberta Health Services, and requires working in partnership with parents. So where the parent concerns and questions are not only prioritized in the visit, but they drive the focus of the visit. And this approach to the Well Child Clinic visit was also reinforced by the public health nurses that we interviewed as well in our validation interviews, in our environmental scan that Farah will talk more about. And cost neutrality was our third guiding principle, because we knew that there was no new funding or resources available to undertake this work. As well, there was absolutely no intention to find any cost savings. We just had to work within the current resources that we had, and we achieved that with this project. So now I'm going to pass it over to Farah, who's going to talk about gathering the evidence, the last three steps in the process.
Okay, thanks, Maureen. So we knew that this work would be challenging and we would need to be guided by evidence from a variety of sources. And as a first step, we began to think about how we were going to make decisions about which non-immunization activities to prioritize in this work. So this slide talks about criteria that we considered important to decision making, and that included required organizational policies or directives for practice, patient safety, alignment with other organizational priorities, evaluability, literature-informed best practice, potential for improving the health of the population, parent priorities, and feasibility. And we looked to see if there were any examples of criteria that we could use for this type of exercise, and we didn't find any that was suitable for our purpose. We set out to create our own. The decision-making criteria helped to identify which types of evidence were needed and guided the project work that needed to be completed going forward. So we conducted an environmental scan, as Maureen mentioned, to really understand what was happening around the province, all the current practices and tools that were being used at each of the 6 Well Child Clinic visits. All of the Well Child Clinic manuals, practice, and support documents were requested and reviewed to identify any current non-immunization activities that were occurring across the 5 zones. And this data was validated through key informant interviews with public health nurses. It was really important for us to understand the details of each of the activities in order to really identify consistencies or variations in practice that were occurring across the province, and also to collect enough details about the intervention for the review of evidence that followed. In all, we identified 19 different activities that were occurring in the Well Child clinics. The activities that were being done more consistently across the province, we found were ones supported with provincial documents such as provincial policies, guidelines, or resources. For us, conducting the environmental scan, including the key informant interviews that were conducted, were a really, really good opportunity to engage stakeholders across the province beyond our provincial working group and others in the governance structure that Maureen talked about. Next, we conducted a rapid review of the literature for each of the Well Child Clinic activities to see if there was evidence of effectiveness to support the current clinical practices. Systematic reviews were primarily used, and where these weren't available, we used clinical practice guidelines and individual research studies. We searched the Cochrane Library as a first step, and then looked at Google Scholar, Cumulative Index to Nursing and Allied Health Library, PubMed, and Medline if searches of Cochrane weren't successful for us. The evidence review gave us insight into which activities were effective and also information about the best clinical practices. Another piece of evidence was understanding parents' needs, perspectives, and expectations of the Well Child Clinic visits. Oops, sorry, I'm behind here. My apologies. Since we couldn't engage with the parents directly, it wasn't possible for us at the time, we completed a review of research literature. We looked at local evaluation and quality improvement data, as well as national level reports that looked at parents' primary concerns during infancy and early childhood period. The parents' priorities were ranked based on the most frequently occurring topics, and the resulting list of parents' priorities that you see on the screen are not listed in any order of importance. We also completed a review of our internal organizational policies, provincial directives, and priorities by looking at our internal website for information. Our stakeholders were also asked to send us any zone-level policies that determine practice requirements. We found 4 Well Child Clinic activities that were directed by policies and priorities, and these included postpartum depression screening, child growth measurement, safe sleep environment, and tobacco and smoke-free environments. We also looked at the potential for improving the health of the population by reviewing the Well Child Clinic activity-related data from population-level health status assessments. Evaluability was assessed by looking at the capability of monitoring health outcomes of each of the Well Child Clinic activity through our existing data systems. Our stakeholders also weighed in on the patient safety and operational feasibility aspect of each activity as we did this work. So how did we actually make the decisions? We needed to create a process to make decisions as none existed to guide us, which is exciting as we could really think outside the box. Once all of the evidence was gathered and synthesized, the decision-making criteria that I spoke about were revisited to assess how well each of the Well Child Clinic activities scored on each of the criteria. We used a ranking exercise, and each stakeholder independently applied a 3-point scale to the criteria for each activity. The scores of each of the criteria were added, resulting in a total score for each activity for each stakeholder. And then these activities were ranked from top to bottom for each stakeholder based on the total scores. We used a Delphi analysis for consensus building based on the median of total aggregated score for each activity to determine the final ranking of activities, which were then used to guide conversations and build consensus with our stakeholders around which Well Child Clinic activities should be prioritized or discontinued. Consensus regarding which non-immunization activities should be consistently offered in public health Well Child Clinics was achieved, and fairly quickly, and we attribute this to continuous stakeholder engagement and collaboration throughout the process. So here are the final recommendations for well-child clinic standardization in Alberta. There are 14 non-immunization activities that are divided into routine or non-routine activities. Based on patient and family-centered care that Maureen talked about, a routine activity will be prioritized based on parent questions, concerns, and or nursing clinical judgment. And these activities included infant and young child feeding and nutrition, child growth measurements, injury prevention, family adjustment, postpartum depression, tobacco exposure reduction, and safe infant sleep. And based on patient and family-centered care, a non-routine activity will only be addressed based on parent questions, concerns, and or clinical nursing judgment. And these activities included domestic violence, general development and behavior, hearing, developmental dysplasia of the hip, oral health, head, which included pelagiocephaly, fontanelles and sutures, and vision. Categorizing activities within routine and non-routine really helps provide guidance within the time constraints of the visit on what activities to focus on as opposed to trying to cover them all. It also puts the emphasis on patient and family-centered care and preserves and enhances the ability of the public health nurse to use clinical judgment. For example, in a visit based on parent questions related to breastfeeding, which is a routine activity, the nurse may focus most of the visit on breastfeeding support. On the other hand, the nurse may focus the visit on concerns with general development and behavior, a non-routine activity if concerns related to this topic are either expressed or identified. This slide looks at a template for reference tables that has been developed for each of those activities that I mentioned, both routine and non-routine, to give guidance to the public health nurses for implementation of the recommendations. It identifies the activity we're talking about, the associated intervention, whether it's a physical assessment, physical measurement, screening, health education, and or anticipatory guidance, the resources for parents and health professionals, as well as documentation information and guidance for referral. As Maureen alluded to earlier, one of the key deliverables of this work was to ensure that the elements of the public health clinical documentation system that we use in Alberta, Meditech, aligns with the recommendations to ensure that data elements required for both evaluation and surveillance activities were included. So what did we learn from all of this? This work has certainly highlighted, and I would say validated, many factors that influence public health decision-making. Evidence from a variety of sources must be used because of the many factors that need to be considered in designing public health interventions. To add to this, as I'm sure no one would argue, the lack of certainty in public health literature and challenges in measuring health outcomes also makes decision-making both a science and an art. One of the facilitators of this work was the fact that Alberta Health Services came into being as a single health authority over 10 years ago now and has remained fairly stable since. We suspect consensus building would have been more challenging if this work had been in the early days of the formation of AHS. Because of this stability, the stakeholders were quite familiar with each other from work on other provincial policies and projects. The a priori creation of criteria for decision-making, continuous and I would say broad stakeholder engagement, and the collection of evidence from a number of different sources were essential in facilitating this work and in the group coming to consensus. So I'm really excited to note that we are in the implementation phase and in the process of implementing the standardized non-immunization activities across Alberta as we speak, actually. Our communication plan is in progress and includes engaging physicians to inform them of the standardization work in Alberta Health Services. Some zones are opting to use a self-study module that we've developed for implementation, while others have asked for presentations between November and December from our team to support the implementation. We have developed a logic model and evaluation plan, and that's in final stages, and we'll be in consulting with our stakeholders on that. We anticipate implementing the evaluation approximately 6 months to a year post-implementation, depending on what challenges come forward and how things are moving forward in the next little while. So that brings us to the end of our story. Thank you for listening, and we'd be happy to take any questions that you might have.
Great. Thank you so much for that presentation. And just to note that Maureen and Farah's email addresses are also available in the chat box if you do want to contact them about their work. So again, you can send in your questions through the chat box by sending them to all participants. And just to start off, I have a question. So will this process, do you think it will be revisited again in the future? Do you anticipate doing like another round of prioritization in the future?
So it's a really good question. I think that, you know, as we're rolling this out, there's been lots of questions around decisions that have been made and some of the challenges that might come forward. So as part of our work, we really feel that the evaluation work will really help to highlight, you know, some of those quality improvement pieces as well. And so we hope that we'll be able to revisit once the evaluation has been completed and the recommendations from that. So that, you know, probably in a year and a half or so, we'll be able to revisit and see if we've, if the activities that we have identified, in fact, need to stay as routine and non-routine, or maybe there might be some shifting.
Exactly.
Great. And I imagine that's also a good way to make sure you're staying current with the literature as well as more gets published.
Yeah, absolutely.
So we do have time as well for questions for Lori and Dr. Ward. So I have one more question for all of our presenters today, but I will just jump briefly to a question for Lori and Dr. Ward that came in earlier. So the question is, what are Peel Region's strategies for generating evidence to contribute towards evidence-informed decision-making?
It's Megan. I'll start with that one. We are a local public health department, and our mandate does not include primary research. So we're not actually generating research, except we do partner with researchers who are interested in particular applications that fit well with our mandate. And in those cases, we're partners with academics and researchers who are producing primary research. But aside from that, we're actually not producing much primary research at all. We don't really hire people who are researchers for the most part because it's not in our mandate. And so we would have limited skill sets relative to those of our academic partners.
Great, thank you. So my question for both of you, and I've been asking this in the other webinars as well, is how do you see your work perhaps translating across Canada, since we do have a national audience? So maybe we can start with you, Lori and Dr. Ward, and then we'll go over to Farah and Maureen.
Well, we've had a lot of interest in our methods and tools for evidence-informed decision-making at Peel Health. For example, on the library website where our research reviews are publicly posted, we've had, I think,
more than 250,000 hits.
More than 250,000 hits on the research reviews. So we share those in the event that the evidence reviews are useful to other public health practitioners. And we participate as much as possible in conferences, in many of the activities of the NCCMT, including this webinar, and we get a lot of direct communications from public health practitioners, and we are more than happy to share our experience and our tools and our learning, really, throughout this journey.
I would say, it's Megan, I would say in addition to that, and specific with the knowledge broker role in an organization, that for me the role creates a bridge between research evidence and practice. When you're in local public health, as we are, you're in the business of delivering service, creating policy, and so on for the people of your region. And honestly, what happens in the research world is kind of far afield. And a lot of times we need to have a bridge to understand the important things that are produced in research and how they might, in fact, apply to the health issues that we're addressing at local public health. So I think the question for organizations, local public health organizations across the country is, is this a role that your own health department could benefit from, this kind of bridging role? And if so, I mean, certainly our experience is that it has really enhanced what we can do in terms of bringing research into the conversation around decisions we want to take.
And Farah and Maureen, do you have anything to add?
Yes, we do. First off, we'd like to say thank you to you for giving us this opportunity to present this work on a national webinar, as well as publishing it in your casebook. So we are very appreciative of that. When we started working on this project, we really were looking to other regions to understand if they were confronted with similar issues, how they had managed to do any sort of standardization in well-child clinic, and how they selected the activities that they did. And what we did find was that I think nobody really had taken a systematic approach to this type of work. So we would love for other regions to try and duplicate what we did, learn from it, and share their learnings with us as well, so that everybody could learn from this process, because it really truly was a novel approach. When we complete the evaluation, we will absolutely look to publish those results as well. And then we do post all of our reports and publications on our external website within Alberta Health Services, and we'll certainly try and attend conferences and do what we can in terms of knowledge translation. Do you have anything to add, Farah and Dolly?
I think that covers it really well. Yeah, I want to echo Maureen to say if there's any other regions interested, because when we checked, they had certainly done this work. They had sort of reorganized their public health services, but none had a process that we could really adapt for our use. And so because this is such a novel approach, if possible and if interested, others could definitely learn from us and add to the learnings that we've gained as well. So that would be a strong ask for others to think about this.
That's great. So I know you just mentioned that you're aiming to make your reports available online. Would people be able to contact you for more specifics about the tools themselves? So like the the tools that you use for the ranking and prioritization process?
Yes, absolutely.
Yeah.
Okay, excellent. So I don't see any more questions coming in today, so I think we'll wrap up the Q&A portion with that. Sounds like Maureen and Farah, as well as over at Peel Region with Dr. Ward and Jackie Nearson, would be willing to field any more questions that you might have by email. So just a quick note here. So again, I would like to thank all of our presenters for presenting today on their work. It was very informative, and I know I really enjoyed hearing about all of this work. So if you are using EIDM in your practice, we would, or if you would like to support, if you would like support for EIDM, we would like to hear from you, and we can be contacted at NCCMT@mcmaster.ca. We would also appreciate it if you would take a few minutes to provide some feedback for us on this webinar. So there is a short survey available. The link is in the chat box, and the survey should also open when you close out of WebEx. We also offer a number of webinar series from the NCCMT if you're interested in our webinars. So those include Spotlight on Methods and Tools, topic-specific methods and tools, an online journal club where we practice critical appraisal of a journal article, as well as our peer-to-peer webinar series. So again, I'd just like to thank everyone for joining us today for this webinar. If you have any questions, please do not hesitate to contact us. Our email is again on the slide, as well as in the chat box. I will just pass it over to our presenters for a second if you have any final thoughts or comments you would like to share.
It's Lori here at Peel. I would just like to thank Claire for all of the organization and for the support for the webinar today. And also, I'd just like to reiterate how valuable I think the EIDM casebook is, and thank NCCMT for that. And thanks for the opportunity to share our story today.
Oh, you're welcome. We certainly love being able to offer these types of resources to people. And so with that, we will end our webinar today. Thank you everyone for joining, and I hope to see you all at a future webinar. Thank you. Have a great day.
Thank you.